Hi, we are NEC, a team of master's students from the Johns Hopkins Center for Bioengineering Innovation and Design, working to enable earlier detection of neonatal necrotizing enterocolitis. In the summer of 2019, our team was immersed in numerous intraoperative and critical care settings at the Johns Hopkins Medical Institute to identify innovation opportunities related to patient monitoring. We observed procedures in the cardiovascular operating rooms and critical care being provided in the cardiovascular intensive care unit, the neurological critical care unit, the surgical intensive care unit, and the neonatal intensive care unit. The most impactful needs that we identified were all focused on monitoring and caring for patients in the neonatal intensive care unit. During our clinical immersion in Baltimore, we visited two different NICUs. The Johns Hopkins Hospital has a larger Level 4 NICU with private rooms. A majority of their patients are born at less than 30 weeks gestational age, and about a fourth of all patients are transferred in from other hospitals. At Johns Hopkins Bayview, a community hospital, their NICU is an open bay with about half the capacity of the main hospital. It is only a Level 3 NICU, meaning that it offers less acute care to patients and does not offer access to major surgeries on site. We also traveled to St. Petersburg, Florida to observe in the NICU at Johns Hopkins All Children's Hospital. It is a very large Level 4 NICU with almost 100 beds on site, offering the most advanced life support and monitoring technology for premature and critically ill infants. After our clinical immersion, we got a good grasp of the average patient pathway in the NICU. Once infants are born, they will either come into the NICU from the same hospital that they were born in or transferred to another NICU that best fits their needs. These infants can be admitted to the NICU for a variety of reasons, including congenital heart defects, respiratory distress, or just prematurity itself. While infants are being cared for in the NICU, providers look for signs that the infants are developing well, including respiratory and hemodynamic stability using extensive monitoring. When the infants are stable enough, especially by being able to control their body temperature, they will either be discharged to go home, moved to a post-acute hospital, or transferred to the pediatric intensive care unit to receive more life-supporting care. Although these very fragile infants are monitored extensively for vital sign parameters like heart rate, oxygen saturation, blood pressure, and temperature, there remains one particular pathology that is very challenging to detect. Existing monitoring technology has been unable to improve both the morbidity and mortality rates for this disease in nearly 4 decades. Our team identified a major gap. Although these infants are constantly monitored in the NICU, early detection of certain disease states often go unnoticed with the monitoring systems currently in place. Necrotizing enterocolitis, or NEC, is an inflammatory intestinal disease that can affect seemingly healthy newborns. While often affecting premature infants, this disease can onset and be life-threatening within 24 to 48 hours. NEC is a devastating disease. It is the #1 cause of death in very low birth weight infants, those weighing less than 1,500 grams, and the #1 surgical emergency among all NICU patients. Every year, over 380,000 premature infants are born in the United States. Of those infants, 90,000 are at the highest risk for developing NEC. These infants are born having either a very low birth weight or congenital heart defect. Annually, 5,400 infants will be diagnosed with definite NEC, and 800 of them will ultimately lose their lives to this disease. So why does NEC occur? Premature infants are predisposed to NEC. Research indicates that more than 90% of all cases occur after infants begin formula feeding. These infants have not yet developed the ability to completely digest and absorb nutrients from their feeds. Their gut is underdeveloped, which facilitates bacterial colonization. As a result, these infants are prone to infection, which can quickly progress to bowel necrosis. Current methods for detecting the onset of NEC have proven to be insufficient in detecting the disease at its earliest stages. These methods include nurse-led physical exams, which occur every 3 to 4 hours in the NICU. Nurses take the girth measurement by wrapping a tape measure around the infant's abdomen. These exams are both subjective and infrequent. X-ray is the diagnostic gold standard for NEC. Serial X-rays are ordered for patients with suspicion for NEC, but this method is only effective at detecting many of the late-stage indicators of the disease. Abdominal ultrasound is used at some NICUs when X-ray results are inconclusive, but no protocol exists to diagnose NEC based on its findings. All of these methods lack the ability to provide early-stage detection of NEC. NEC is a multi-stage disease. Bell's modified staging criteria breaks down the disease development into 3 stages: suspected, definite, and advanced NEC. When laying out both the physiological and clinical manifestations of NEC at each stage, you can see that on X-rays, clinicians often look for dilated bowel loops, bowel perforation, and free air in the abdomen. These signs present as some of the latest indicators of NEC. Observing these issues firsthand led us to determine that neonatologists and nurses in the NICU need an improved means of detecting necrotizing enterocolitis in premature infants in order to increase early-stage diagnosis and enable earlier treatment. We have collaborated with 54 clinicians and specialists to gain a diverse perspective on the problem. Stakeholders unanimously echoed that the need to detect and treat this disease earlier is glaring. With their expert guidance and support, we are uniquely positioned to tackle the development of a solution. NEC can be treated either medically or surgically. Currently, 60% of all definite NEC cases are treated medically, which carries a mortality rate at 6%. Medical treatment includes broad-spectrum antibiotics and withdrawal of feeds. The infants are placed on intravenous nutrition for 14 days. However, 40% of definite NEC cases require surgical intervention to remove necrosed bowel, which carries a 30% mortality rate. Those infants who survive surgery deal with lasting morbidities such as growth delay, neurodevelopmental impairment, intestinal strictures, and short bowel syndrome. Our technology will detect NEC at its earliest stages to increase the number of cases that can be treated medically rather than surgically, thereby improving outcomes for premature infants. NECcheck will improve outcomes by targeting disease detection in stage 1 of the disease, when clinical suspicion is still nonspecific and uncertain. Detecting the risk of NEC onset in this early stage will allow clinicians to tailor feeding schedules, guide antibiotic administration, and escalate imaging vigilance to more closely monitor the infant. From a performance perspective, an effective solution to this problem would ideally be continuous, objective, and automated to circumvent the limitations of current clinical assessments and imaging modalities. To effectively address the user needs, this technology must provide an evaluation that is comparable to the current clinical standard of care, integrates seamlessly into the NICU workflow while considering the fragility of these patients, and ultimately detects the earliest disease progressions within the patient. Along with developing a solution, we have also determined an optimal pathway to market. Hospitals will be incentivized to adopt our technology from both a clinical and financial perspective. Clinical benefits include a reduction in morbidity and mortality due to treating NEC medically rather than surgically. Decreasing the number of surgical interventions can reduce the length of stay in the NICU, which currently adds an additional 60 days on average. This disease is expensive. The average cost for medical treatment of NEC is $55,000 per patient. Late detection and surgical intervention tax on an additional $180,000 per patient. Our target market includes all Level 4 and Level 3 NICUs in the United States, as they are equipped to care for premature infants and correspondingly see the most NEC cases. Level 4 NICUs are the highest level NICU and care for infants born less than 28 weeks gestational age and have advanced surgical capabilities. There are 69 Level 4 NICUs in the United States. Level 3 NICUs, which total 785 in the United States, care for infants born greater than 28 weeks gestational age and those that weigh less than 1,500 grams. By leveraging our clinical champions and increasing awareness of our device through presentations at pediatric conferences, we can get our product in front of NICU purchasing committees and sell NECcheck directly to the hospitals themselves. In the NICU at Johns Hopkins Hospital, there is a clear protocol pathway to transitioning from physician-directed use of a technology to making it standard of care. 1 to 2 clinicians must be interested in the need for this technology. They will then approach a working group at the hospital to propose the protocol change. Guidelines for specific action to take will then be developed based on sufficient data. The working group will ensure workflow fit for pertinent users like the nurses. They will also continue to reevaluate the efficacy of this change. The path to commercialization for a medical device requires 3 considerations: intellectual property, regulatory requirements, and reimbursement strategies. As our solution is novel, useful, and non-obvious, we will be obtaining patent protection and have freedom to operate as well. For our regulatory pathway, we will be pursuing a de novo reclassification for our device. Since it will be indicated as a low to moderate risk device, the de novo will classify our solution as a Class 2 FDA-cleared device requiring a 2-year clinical study to generate evidence of safety and effectiveness in the target patient population. As for reimbursement, there are currently no reimbursement codes for this device, as nothing like it exists in the market today. NECcheck is indicated for use as an objective bowel health monitor for infants at risk for compromised bowel function. Our indications ensure that we meet the criteria of a non-significant risk device. This means that we do not require an investigational device exemption to begin our 2-year clinical trial to prove safety and efficacy for NECcheck in our de novo reclassification. In order to ensure the study is sufficiently powered, we expect enrollment and execution of the clinical trial to take about 3 years. In the coming months, our team will complete our alpha prototype, compare device performance to clinician gold standard of NEC assessment, and gauge adoptability of NECcheck with clinicians through a usability survey. Future iterations will be developed based on this clinician feedback. Our team consists of mechanical and biomedical engineers. We would also like to thank our wonderful and supportive committee consisting of clinicians, NEC researchers from the Hackham Lab, and mentors from the Johns Hopkins Center for Bioengineering, Innovation, and Design for making this project possible by supporting us every step of the way this year. In the words of Dr. David Hackham, Chief of Pediatric Surgery at Johns Hopkins Hospital, "Until we never have to treat another tiny infant with NEC, we will not stop looking for cures. We will not stop working with families, with nurses, and with doctors everywhere to provide comfort and to offer hope." Our team was inspired by the fight within all the infants that we observed in the NICU. We aim to be a part of NEC Awareness Day on May 17th. We are NECcheck, enabling earlier detection of neonatal necrotizing enterocolitis.